Hello, everybody. Welcome back to Bewitching Brain. Really happy to have you with us, and please subscribe and share, and please take care of yourself during these difficult and trying times. So my name is Andrew DeGroat. I am a M1 student, and today we're going to be talking about ALS. But in the last video, we talked about reflexes, how they work, and some examples of those reflexes that doctors assess clinically. So far in the spinal cord series, we've discussed spinal anatomy and cross-sectional arrangement of the spinal cord, as well as sensory and motor tracts of the spinal cord that you'll be seeing again today. Understanding how these spinal and motor and sensory tracts function normally is important in setting up your learning for pathology. In this video, we'll be discussing ALS or amyotrophic lateral sclerosis. It's also known as Lou Gehrig disease in the US. So foundational concept number one, we're going to be talking about the differences between upper motor neuron and lower motor neurons. So upper motor neurons are neurons that originate from the motor cortex or brainstem, and they influence in general activities of lower motor neurons. Most of this activity is inhibitory, as we're going to see soon, but examples of these are the corticospinal and the corticobulbar tracts. The corticospinal tract is one for movement in your lower limbs and extremities, and your corticobulbar tract is movements and sensory tracts in your face. Okay, so lower motor neurons then are located in the ventral horn of the spinal cord, and these are generally housed by alpha motor neurons that directly innervate skeletal muscle, and they're influenced by that corticospinal tract I was just talking about. So what do these deficits look like? So in the upper motor neuron section that we just talked about, lesions here are going to be as follows. Usually hypertonia is characteristic. Hypertonia is too much muscle tone. Hyperreflexia is overly reflexive, and you get mild to absent atrophy. So if you lesion the upper motor neuron, like I said before, it's mainly inhibitory or smoothing out those reflexes. If you have a lesion, usually it's overpronounced to the stimulus. And importantly, while we're getting into these topics, it's important to consider what is normal for that person. And it is important to ask yourself too, are the deficits or findings, are they lateral or bilateral? But mostly it's important to feel out if there's any pathophysiology there for that specific person. Because, for example, hyperreflexia is prominent in young athletic men, for example, and sometimes depending on certain medications too, it can cause, for example, clonus in some people, for example, that are taking SNRIs and such. Okay, so additionally, lower motor neuron lesions are kind of the other side of the coin. It is shown by hypotonia, so a lack of muscle tone, hyporeflexia. So if you hit that patellar tendon, you won't get any response. And it is also coupled to significant atrophy, which is caused by when you have a degeneration of lower motor neurons, you lose that innervation to those muscle fascicles. And because those muscles aren't being stimulated by anything anymore, you're going to get significant atrophy, which is a different finding from the upper motor neuron lesions. And also you get fasciculations, which are kind of like ripples of movement in muscle groups on the surfaces of skin that are uncontrolled. Okay, so what causes ALS? So the big thing that was found to be correlative with this disease is a deficiency in superoxide dismutase. This causes protein to aggregate, and accumulate in the spinal cord, which can be toxic to neurons, and you have degeneration in that way. And you get formation of this fibroglial scar, which essentially forms this insulation that electrical activity cannot pass through the spinal cord, and you can have inhibition that way. So the signs, symptoms, and treatment. ALS is kind of a textbook mixture of upper motor neuron and lower motor neuron lesion. When you have a patient that presents to clinic, often they'll have hypertonia, hyperreflexia, atrophy, and fasciculations. So some additional symptoms as well is that you have progressing weakness. That's really a key feature for you. When you hear progressing weakness, you should really start thinking about ALS and upper motor neuron or lower motor neuron lesions, and how it travels. So this one travels from extremities to the respiration and then to the brainstem finally. Also, another symptom correlated with ALS is a positive Babinski sign, which is also a sign for upper motor neuron lesion. However, this is a new one for you guys. A Babinski sign is actually completely normal in people, or rather in babies that are less than 6 months of age. However, after that time, everybody loses that Babinski reflex, so to speak. So if you rub your foot along your toes with a reflex hammer, somebody that is less than 6 months of age, they'll have their toes fan out and it'll stay there. However, in a normal adult, what you'll have is, if you do the same test, the toes will curl down towards the sole of their foot. That is completely normal. So a positive Babinski sign is when you have an adult that you do that test on and they have their toes fan out. That is a abnormal finding. But interestingly enough, with ALS, this positive Babinski sign decreases with disease advancement. With ALS, you have no sensory loss because it's not affecting those dorsal spinal tracts, and sometimes it's coupled with frontal temporal dementia. And unfortunately, there is really no treatment. It's mainly palliative care. There is no effective solution to help cure somebody of this disease, but you can try to delay the progression. It's mainly palliative care, and there's a new medication that came out, Riluzole, I believe, and it is a glutamate inhibitor, and it helps you manage those symptoms. Okay, next time we're going to be talking more about the brainstem structure and function. And again, thank you for listening and tuning in. And thank you to Dr. Patitucci for those spinal cord illustrations. And please take the post-series survey in the link below the video. And just take a couple minutes to do that. Thank you so much. Have a good day.